Greetings from Boston. My name is Greg Maddie, and I am the Chief Perfusionist at Boston Children's Hospital. Today, I would like to share with you a talk which I put together, which looks at the use of a hemoconcentrator throughout the operative period. And I have titled my talk, The Hemoconcentrator, Unsung Hero of Pediatric Cardiac Surgery. I chose that title because I truly believe that the hemoconcentrator can be a powerful workhorse for the perfusionist and surgeon in the operating room when used to its fullest potential. I have seen many presentations over the years looking at different hemoconcentrator uses in isolation. My belief is that the use of a hemoconcentrator for pediatric cardiac surgery must be considered collectively, and we will get into that in the upcoming slides. So for discussion today, we will discuss what a hemoconcentrator is, when we use it, why we use it, and very importantly, how exactly we can use it. That is a very important question we will cover. As I mentioned previously, it is my belief that your ultrafiltration practices must be considered collectively. So for starters, what is a hemoconcentrator, or what is an ultrafilter? Today, I will use the words interchangeably as most people do. I chose to display the technical specs for just two small hemoconcentrators today as they are very commonly used. My practice utilizes the Mintec HPH 400 for neonates and infants, while I know that many pediatric centers also use the Sorin DHF02. Both are quite comparable, and I do not see a realistic clinical advantage between the two. I will note that I typically limit overall flow through the device to 350 milliliters a minute based on the experience that flow rates of 400 or 500 a minute increase the risk of disconnects with the high pressures generated. I won't spend time on how an ultrafilter works because I believe everyone here today understands that very well. Though a key concept is that hemoconcentrators remove fluid, electrolytes, and small particles, including mediators for inflammation, lactate, and other evil humors, as we like to say here in the United States. This knowledge has driven the use of hemoconcentrators in pediatric cardiac surgery from occasional use to universal use. And that universal use is because the hemoconcentrator can be used during all of the distinct phases of cardiopulmonary bypass. Before bypass with pre-bypass ultrafiltration, while on bypass with conventional ultrafiltration, and of course after bypass with modified ultrafiltration. We do not have time to discuss a literature review of pre-bypass, conventional, and modified ultrafiltration, but I also do not think it's necessary. Intuitively, it makes sense to optimize the pump blood whenever possible and to return as much patient whole blood to the patient as possible after a surgical case. And that speaks to why we are using ultrafiltration during the distinct phases of bypass. In the pre-bypass period, ultrafiltration, or PBUF, is a very simple and effective tool to make blood primes more physiologic. There is typically ample time before the pump run to perform this, and at Boston Children's, we devised a system which allows for flexibility in case there is no time, as with an emergency. We commit to the procedure of PBUF only if time permits, and frankly, I would estimate that more than 99% of the time it does. Moving on to the bypass period, conventional ultrafiltration, once again, is the practice of simply removing excess volume, whether it be from patient volume overload, fluid returned to the pump reservoir from valve test solution, or volume from cardioplegia delivery. But importantly, one should also use ultrafiltration during the case for zero balance ultrafiltration if blood products are added. This simply involves adding balanced electrolyte crystalloid solution in an amount similar to the blood volume added, and then removing that volume. Just as was the case with pre-bypass ultrafiltration, this will improve electrolyte disturbances caused from the bank blood. I would add that in my practice, I aim to add any required blood to the pump before cross-clamp removal, such that zero balance ultrafiltration can be completed before cross-clamp removal. This allows the heart to see more physiologic blood with improved electrolytes during during initial and early reperfusion. Finally, ultrafiltration can be performed after bypass with MUF. I have a keen interest in MUF, as no one can argue that it intuitively makes sense to return as much patient whole blood from the circuit as possible after the pump run. But as you will see in the upcoming slides, just exactly how you perform MUF is exceptionally important as well. Now, most often when I discuss hemoconcentration with other centers, I discover that they use passive ultrafiltration during the case, and also beforehand if they employ pre-bypass ultrafiltration. This diagram shows a typical setup. Note that the source of blood for the hemoconcentrator is post-oxygenator. The hemoconcentrator flow is passive and is determined in part by the overall system pressure. If you are doing a neonatal case or utilizing low flow, your hemoconcentrator flow and the ability to remove fluid will be limited because the driving pressure will be low. Also note that the flow through the hemoconcentrator in this arrangement is such that flow enters the bottom of the device and exits the top. Air is continuously purged to the reservoir. Additionally, this type of setup allows one to switch to active ultrafiltration, providing ultrafiltered blood flow with a pump head after bypass to perform MUF in the traditional manner. Some people use the cardiplegia head for this purpose. There are numerous options. This is not how we do things in my practice. Therefore, it is important to describe exactly how I set it up or how my practice sets it up. It is my belief that perfusionists should standardize to active ultrafiltration for the entire case for a few simple reasons. And this active ultrafiltration must source blood from the venous limb of the circuit. That is exceptionally important to prevent the possibility of entraining air into the blood across the hollow fiber membrane oxygenator. So let's take a look at the setup that I believe is exceptionally safe and effective. This diagram shows an exclusively active ultrafiltration setup for all types of ultrafiltration. Here, there is a mini pump head which always sources blood from the venous line. It pumps blood to the top of the hemoconcentrator, and then that blood exits the bottom and can go back to either the reservoir or to the pump boot line. In this manner, it serves as an air trap. The return is to the reservoir for PBUF and for conventional or zero balance ultrafiltration. The return is to the pump boot line during our method of veno-arterial MUF. This setup is a variation of the technique first described by the Halifax, Nova Scotia Perfusion Group back in the year 2000. To note, there is no possibility of this head pulling air across the hollow fiber membrane oxygenator. Any negative pressure would be exerted on the venous line and would therefore pull from the venous flow or the reservoir through the venous straw connection. Using this arrangement allows one to utilize a single, consistent method of active ultrafiltration throughout the case without relying on a system pressure and the variable shunt that can occur with passive ultrafiltration. And during MUF, I believe it is safer. There is no cerebral steal, which is particularly noteworthy if you do not have access to NIRS. There is no coronary steal. But to note, ultimately with this method of MUF, there is no afterload reduction, but there is preload reduction, so that must be considered. But first, let's look at the phases of the operation in which ultrafiltration is used in more detail. The first phase to discuss is pre-bypass ultrafiltration, or PBUF. There is no industry standard for this technique, but all methods have the same goal of improving blood primes such that they are more physiologic. As I mentioned earlier, we use a method which has the perfusionist perform a standard blood prime, and then PBUF can be performed afterwards. In a neonate or infant circuit, after standard blood priming, we add 100 milliliters of plasmolite and 80 milliliters of half-normal saline to the circuit. This volume is hemoconcentrated off, and 300 units of heparin, 5 milliequivalents of bicarb, and 100 milligrams of calcium gluconate are added to the circuit to account for losses during ultrafiltration. This method has resulted in exceptionally consistent primes for our small patients. This table shows our initial experience in 300 babies. You will see that many of these values improved towards normal with PBUF, but also important to note is the fact that the variation from case to case was much less. We no longer have potassium levels, which are sometimes very high, just as an example. Certainly, PBUF makes blood primes more physiologic, and we plan to adjust our technique further towards normal after we study outcomes with the current technique. Here is a quick video depicting PBUF. In the interest of time, this video will be played in fast forward mode at 4 times normal speed, since much of what occurs during pre-bypass ultrafiltration is simply adding volume and then hemoconcentrating it off. The perfusionist has completed the blood prime and is ready for pre-bypass ultrafiltration. The reservoir level starts at 75 milliliters and 100 milliliters of plasmolite are added. Then 80 milliliters of half-normal saline is added. The ultrafiltration head is turned on and the ultrafiltrate line is removed. The volume is taken back down to 75 milliliters. As a reminder, the flow path is from the venous line to the ultrafiltrate head to the ultrafilter top, out the bottom, to a stopcock that connects to a line which returns to the reservoir. Once the volume is down, 5 milliliters of bicarb is added, followed by 300 units of heparin and 100 milligrams of calcium gluconate. The ultrafiltration head is eventually turned off and a prime blood gas is sent. And here are the specific results for PBUF on this case. Note that several values like the pH, PCO2, PO2, and calcium are unchanged, but that there were positive improvements in the sodium, potassium, glucose, lactate, and osmolarity. I cannot stress enough that this is an exceptionally simple technique to perform. Transitioning to ultrafiltration during bypass, this quick video shows active conventional ultrafiltration with the same blood flow path as that which was used for PBUF. Again, this technique is very simple and easy. Active ultrafiltration can be performed at any time during bypass. The flow path is the same as that which was used during pre-bypass ultrafiltration, running from the venous line to the ultrafilter head, to the top of the hemoconcentrator, to the bottom, and then back to the venous reservoir. The ultrafiltration head is simply turned on as needed. The process is simple and effective, and it does not needlessly add a shunt to the arterial limb of the circuit. And finally, we come to modified ultrafiltration, or MUF, which is performed after separating from traditional cardiopulmonary bypass. The one change to the active ultrafiltration circuit is that the stopcock on the boot line is turned to direct hemoconcentrator flow to the oxygenator. This allows the blood during MUF to be oxygenated, ventilated, heat exchanged, and of course, filtered through the arterial line filter, whether that is an external filter or an integrated one. We tend to flow 10 to 30 mLs per kilo per minute during MUF, paying close attention to the preload reduction. If the patient is a neonate, the pulse pressure will decrease too much if muff flows are too high. Vacuum may be applied to the ultrafilter if you'd like, but very often that is not necessary. And here is a diagram of our method of veno-arterial muff in action. Some important benefits of this technique include that if you are using an inline blood gas monitor, the hematocrit sensor is integral to the muff circuit so that you can monitor hematocrit in real time. Another advantage is that there is no risk of drawing air across the oxygenator membrane. There is no risk of cerebral steal. There is no risk of coronary steal. There is no need for a separate heat exchanger. And there is no need for messing with the cardioplegia system. And the arterial line filter remains integral to the muff circuit, which is something missing from traditional muff techniques. Now let's look at the simplified technique for modified ultrafiltration on a patient. I would like to show you a 10-minute muff period in just 2 minutes. And so in the interest of time, once again, the video will run at 4 times normal speed. Now this was muff on a 6-kilo bidirectional Glenn patient. The numbers I would like to reference are the systolic blood pressure, common atrial pressure, and the hematocrit. Those important values will also be shown on the left side here since they may be difficult to see on the video. And please disregard the central venous pressure value, which is shown in yellow on the vitals monitor. That was not in use during this case. And we will go through the 3 phases of muff. The normal volemic phase, where the perfusionist essentially keeps the filling pressures the same using the reservoir volume. Then the hypovolemic phase, where hemoconcentration continues without volume replacement to a lower but safe blood pressure. And then the transfusion phase, when the venous cannula is taken out, placed under saline, and the residual muff circuit volume is flushed forward to get the patient back to a normal volume status. This patient started with a hematocrit of 37, a systolic blood pressure in the 60s, and a filling pressure of 2. The normal volemic phase of muff starts, and the filling pressures actually rise along with the blood pressure as the inotropes are being adjusted. The hematocrit rises to 41. The process continues with reservoir volume being added to the muff circuit. The perfusionist elects to increase the rate of volume removal and adds suction to the canister. All values remain stable as muff continues, and the hematocrit rises to 44 to 45%. The filling pressure returns to a baseline of 2, and the perfusionist adds crystalloid volume to the reservoir to help flush blood through the reservoir filter. The hematocrit rises to greater than 45 and muff continues. The surgeon elects to go into the hypovolemic phase where volume is taken off but not returned. The systolic and filling pressures fall to a low of the 60s systolic and a filling pressure of 1. The venous cannula is pulled, placed under saline, and the transfusion phase is started. The venous line volume and muff circuit volume are flushed forward to return as much circuit volume to the patient as possible. At the end of this case, the systolic pressure was in the 70s with a filling pressure of 2 and a hematocrit of 48. And that is an overview of ultrafiltration and how the hemoconcentrator can be a hero for you and your patient during cardiac surgery when used to its fullest potential. Thank you for your time.